Hello, we are still in our series of videos on congenital abnormalities of the upper respiratory tract. Previously, we discussed laryngomalacia and choanal atresia. In today's class, we will briefly discuss subglottic stenosis, which is the third most common congenital anomaly of the larynx, accounting for 15% of all cases. It is the most common laryngeal anomaly that requires tracheotomy in infants. In terms of male to female ratio, males are affected twice as often as females. The etiology of subglottic stenosis is that there is incomplete recanalization of the laryngotracheal tube during the third month of gestation, which leads to different degrees of congenital subglottic stenosis, with complete laryngeal atresia being the extreme form of the spectrum. There are two types of congenital subglottic stenosis, the membranous and cartilaginous types. The membranous congenital subglottic stenosis is the most common and mild form. It's the result of circumferential submucosal hypertrophy with excess fibrous connective tissue and mucous glands. Cartilaginous congenital subglottic stenosis results from an abnormal shape of the coracoid cartilage. Congenital subglottic stenosis may present with the following clinical presentation. Usually appear in the first few months of life. The stenosis is typically not evident until the child develops an acute inflammatory process which further compromises the subglottis. This period does not differ from croup. Biphasic stridor with or without respiratory distress may be there. Cry is normal but may have barking cough. Difficult to intubate, extubate or decannulate. Children with Down syndrome are at increased risk of developing congenital subglottic stenosis. Upon examination, infants or children may or may not be in respiratory distress. Diagnosis is based on history of recurrent croup. Rigid bronchoscopy is used to confirm the diagnosis. Diagnosis is made when the lumen is less than 4 mm in term infants or less than 3 mm in preterms. Plain lateral or AP radiograph may reveal characteristic narrowing at the level of the subglottis. The most common grading for the diagnosis of subglottic stenosis is the Mayer-Cotton grading scale. Grade 1 stenosis is lumen obstruction less than 50%. Grade 2 stenosis is lumen obstruction between 50 and 70%. Grade 3 stenosis is lumen obstruction between 71 and 99%. And grade 4 stenosis is complete lumen obstruction. Management. Most cases resolve spontaneously with growth. Endotracheal intubation and tracheotomy may be required in patients with significant airway compromise.